Okay, so we just have finished the cyanotic congenital heart disease with increased pulmonary blood flow. The session now is to complete the other arm and giving another example of cyanotic congenital heart disease with decreased pulmonary blood flow. So the lungs are not receiving the same amount of cardiac output like the left side. There is a difference. It's not like one cardiac output to the right side and one cardiac output to the left side. It could be less than one to the right side and more than one to the left side. Just to refresh, this is the normal anatomy again. So we have the right side completely separated from the left side. The right side receives the inferior vena cava blood, which is the deoxygenated blood, the superior vena cava blood, and then goes to the lungs to be oxygenated, only to return back through the pulmonary veins, 2 on the left side and 2 on the right side, to supply the left atrium, the left ventricle, and the aorta, and so on. And by this, we maintain our saturation normal on the left side, and we take the deoxygenated on the right side to send to the lungs to be, or to pump to the lungs to be oxygenated. So let's go through this anatomy of Tetralogy of Fallout and then go about the pathophysiology that we expect from such flow and such anatomy. So we all know that Tetralogy of Fallout is comprised of 4 cardinal lesions or criteria. There is a VSD, so an interventricular, the interventricular septum is not complete. It has a defect, and it's a subarterial defect just below the aorta usually. So we call it a large subarterial or subaortic VSD. That's component number 1. The other important component that Tetralogy of Fallout have, and it has a lot of implications in the pathophysiology, is pulmonary valve stenosis and subpulmonary valve stenosis. That means stenosis or narrowing below the pulmonary valve because of muscle, and at the pulmonary valve itself because of valve abnormality. And you could see not only that, but also the pulmonary tree itself is much smaller compared to the normal. This is the pulmonary valve. It's almost equal to the aortic valve. Look at here how the pulmonary valve is much smaller and the aortic valve is actually larger because it is carrying more cardiac output. Look at here, the sub area is clean. There is no muscle. And look at here, we have this big chunk of muscle narrowing the entrance to the pulmonary valve. So this is number 2 criteria in Tetralogy of Fallout. Number 3, the aorta itself is slightly deviated to the right. It has moved slightly to the right. You can see here the aorta compared to the interventricular septum, it's to the left of it. But here in Tetralogy, it's actually sitting on it. You see, it is sitting on it, or it is overriding it, okay? Imagine this is a saddle and this is the back. It's overriding the septum. And this is criteria number 3. Criteria number 4, there is significant right ventricular muscle hypertrophy. Look how thin the right ventricular wall here is, quite thin. And look how thick I have drawn the right ventricle. All these 4 have pathophysiological implications in such a disease. So let's talk about now pathophysiology. And the only way to talk about pathophysiology is really to follow the blood and keep in mind where the blood likes to go and where is it going to be directed by the lesion that we have in hand. So let's follow the inferior vena cava pulmonary blood flow, superior vena cava pulmonary blood flow. There's no problem of this blood going to the right atrium, isn't it? There's no hindrance, there's no stenosis. The right atrium is low pressure to a certain extent, so it can receive this blood. Going through the tricuspid valve is also usually not an issue, because tricuspid valve abnormalities in Tetralogy of Fallout, though can happen, but they are quite rare. And then the blood needs to go back up in systole to be pumped to the great vessels, the pulmonary artery and the aorta. So if you were the blood, where would you like to go? You have two ways. You either go through the muscle bundle, the stenotic area, and the stenotic almost closed valve, or you have the wide open hole or defect or VSD, and then to the wide open aorta. Obviously, the blood will go both ways, because depending on the resistance it finds, it will choose. And because the hole is there and the aorta is overriding, once the blood goes up, there will be some blood going to the aorta. This is the blue blood, remember, huh? And obviously, for us to live, there has to be blood that goes through the pulmonary artery. So the first thing we notice here, there is an obligatory right to left shunt. The blood from the right side is going to the right ventricle and being shunted or deviated or sent through the VSD to the ascending aorta, and that's the obligatory right to left shunt, and that's the reason for being cyanotic. The main reason, as I can remind you, we said before, the main reason is the mixing and the right to left shunt. Even in total amorous, which we spoke about in the previous part, there is right to left shunt across the ASD to fill the blood, but because of excellent mixing, the blood or the cyanotic blood gets diluted with the red blood, and cyanosis does not become too much. Here, we do not have an issue of mixing on the right side. Actually, the mixing is happening on the left side. The obligatory right to left shunt goes through the VSD, through the aorta, and then the cardiac output that's coming from the left ventricle would go through the aorta. So the mixing is really happening somewhere in the VSD and in the aorta. But because we have stenosis here, this right to left shunt amount or magnitude can differ a lot. The more stenosis, the more right to left. And the more right to left, we can have more cyanosis. So in tetralogy, cyanosis is not a stable number. It's not a stable figure, because depending on how much obstruction we have, we will have more to right to left shunt. But obviously, because the right to left shunt is mixing on the systemic side, it will be much more cyanosis showing. And because there is limited pulmonary blood flow, because of the pulmonary stenosis and the subpulmonary stenosis, we will have more cyanosis. So in tetralogy, we have the two factors working together to make the patient cyanotic, which is the right to left shunt plus the decreased pulmonary blood flow. And as I said, and I'm going to repeat, if we have minimal obstruction here, these patients may not show the cyanosis early in life, the first few days. But as they grow up and as the muscle becomes more hypertrophied, they will show the cyanosis more, because the right to left shunt will become more, because the blood will find it much less easier to go through the pulmonary artery. So this is the hallmark of Tetralogy of Fallout. The right ventricle is hypertrophied with all the consequences that can happen. So the compliance may decrease, the right ventricle becomes more stiff, may have diastolic dysfunction because of significant hypertrophy, especially if left untreated for a long time, which doesn't happen these days in many parts of the world because cardiac surgery is available, but it still is a problem in places where tetralogy is not treated in the proper age. So the second, as I said, is the hypertrophy, and the pathophysiology here of stenosis may continue to develop into even pulmonary valve atresia. That means really no flow will go there because of the severe stenosis or the critical stenosis and the severe subpulmonary stenosis. And then tetralogy of Fallout will need to have to live, for the baby to live, he or she will need to get another source of pulmonary blood flow, which is not uncommon, that we find what we call the patent ductus arteriosus. I'm just drawing it for the sake of drawing in this side, although it is not. It usually comes from the descent, below the arch and to the MPA down there or near the LPA, just for making it close for the drawing part. The PDA will give the blood back to the pulmonary arteries, increasing the pulmonary blood flow and improving the patient saturation. This is only in times when the pulmonary stenosis is critical in Tetralogy of Fallout, or it's actually totally obstructed, totally atretic, and then we will have to have another source. Sometimes the other source in the pathophysiology of Tetralogy of Fallout is not a PDA, it's actually what we call multiple aortopulmonary collaterals. That means because of the atresia here, we may find arteries coming either from the neck vessels or from the descending aorta, like this, collateral arteries coming to supply the lungs with blood flow, and this will keep the patient alive. And that's a very rare form, very complicated form of Tetralogy of Fallout. To complete Tetralogy of Fallout pathophysiology, we said that this area is not only valve obstruction or stenosis. We said that there is actually subpulmonic stenosis. So obviously, because it is muscle and it's because it is subpulmonic stenosis, then muscles do contract. And the faster the heart rate, the faster or the stronger they contract. And hence, patients with Tetralogy of Fallout may develop what we call hypercyanotic spells. Let me just take this part out to be able to write. So Tetralogy of Fallout may have what we call a hypercyanotic spell. What is that? What's a hypercyanotic spell? It is a stage where the patient becomes suddenly much more cyanotic than the baseline. And this relates usually to sudden or significant closure of the muscles below. And this comes either from, mainly from tachycardia. Patient may have pain, may have hunger, crying, many other issues, medications that can increase the heart rate. All of them may add to the pathophysiology of cyanosis in Tetralogy of Fallout, making the patient hypercyanotic. And this is a very unique criteria for tetralogy. It can happen in other cyanotic congenital heart disease with the same anatomy, with PS and sub-PS, but it is mainly known for Tetralogy of Fallout. And it just needs the stimulus, which is either the pain, the hunger, the dehydration, medication. The heart goes much faster. Once the heart is much faster, this muscle becomes much more cyanotic area. I have a very unusual way of describing it. If this is the muscle I'm holding, and I can have my colleague here to help me. Can you come? I'm just going to show you. If I'm contracting not so fast, he will drop the pen through my hand, and you'll see, drop it, let it fall. Do it again. You see, it falls easy. But if I contract very fast, the pen represents the blood flow. Look at that now. You drop the pen. See, it won't go anywhere. I'm holding it. The muscle is obstructing it. Thank you. So, whatever causes tachycardia in Tetralogy of Fallout is a bad thing to have. So, in tetralogies, we like to keep them calm, quiet, in parents' hands, well-fed, not dehydrated, not in pain. All of this is very important to take care of when you are taking care of a patient who has an unrepaired or not surgerized Tetralogy of Fallout. That tachycardia increases the obstruction, so less pulmonary blood flow, and as we said, less pulmonary blood flow means less oxygenated blood going to the left atrium, so this cardiac output is less. Plus, not only that, the right to left shunt now is increased because this area now is obstructed, so there is more blue blood and the baby will become severely cyanotic. If we don't reverse that hypercyanotic spell early by calming the baby, by preventing pain, then it may go to a vicious cycle. The patient now becomes cyanotic. Cyanosis means we're not delivering enough oxygen and enough for body metabolism. The body metabolism goes from aerobic to anaerobic. So now you're producing acid. The baby becomes acidotic. And the more acidotic the baby becomes, the baby starts to breathe faster. This is your normal response for acidosis, to clear away CO2 and decrease HCO3. And by doing that, what is the baby doing is the baby is activating the thoracic pump. And what it's meant by the thoracic pump, that you are actually increasing the venous return back to the heart. You take a breath, you're actually getting the blood in because you're creating negative pressure inside your lung. And the faster you do that, the more blood coming from the body. So that is more blood, blue blood coming in. It will go to the right ventricle. We know this is now very obstructed. The baby is crying, fast heart rate. So there is now more right to left shunt, and that's how it goes, a vicious cycle. So now the baby is acidotic, breathing faster, becoming even more cyanotic. Now we're in kind of a critical situation to really stop that. That's happening. We could not calm the baby. The pain is continuing. Even the mother handling could not do anything. Now we have to act in a different way to really get the baby calm. One of the ways is actually to decrease the heart rate, either by giving a medication that prevents the pain, like morphine, and then now we're moving into more like resuscitation type, or giving a medication that slows down the heart rate, like a beta blocker, propranolol. And once we slow the heart rate, we can reverse. This position, such pathophysiology or hypercyanotic pathophysiology is quite dangerous, quite serious. It may end up in cardiac arrest because of severe cyanosis and severe acidosis. So it may create an emergency situation for emergency intervention, whether we go in the cath lab and open this area with a balloon or a stent, or send the patient directly as an emergency for surgery, and the surgeon will create a shunt between the aorta. We said this is the PDA. Now the surgeon actually can create his own shunt between one of the arteries from the neck. Usually it is the subclavian artery we take, or the root of the innominate, to the pulmonary artery. And now we have restored the blood going to the pulmonary blood flow, so better oxygenation, less cyanosis, better aerobic metabolism. Now we're starting to reverse the whole thing back. So Tetralogy of Fallout, to recap, is an obligatory right to left shunt. So, and mixing happens in the VSD and in the aorta. There is decreased pulmonary blood flow. So the cyanosis is quite apparent and is quite significant, unlike the ones with decreased pulmonary blood flow. There is significant right ventricular hypertrophy, which may affect ventricular, mainly diastolic and compliance function, and this is quite important for post-op surgical outcomes. And we have the unique part of Tetralogy of Fallout, which is hypercyanosis because of dynamic subpulmonary obstruction. Tetralogy of Fallout can go further to have either critical or even pulmonary valve atresia, and then the patient will be duct-dependent cyanotic congenital heart disease, needing a PDA, needing prostaglandin to be started immediately after birth, or an emergency BT shunt either after birth because of no PDA, or because of hypercyanotic spell, or because of other reasons that cannot repair Tetralogy of Fallout. I hope I explained it quite well, and we will go in the next part to cyanosis because of poor mixing.